next speaker, and that's none other than Dr. Ramamurthy, who is a great surgeon. He's been the past president of All India Ophthalmological Society, as also the past chairman scientific committee, and he heads the Eye Foundation group of hospitals. He'll be talking about management of posterior capsular rent. So this is something that we all have. The best of surgeons have posterior capsular rents, and you need to manage it and not lose your cool. So over to Dr. Ramamurthy, please.
Thank you, Dr. Mahipal, for having me in this course. I'll be just showing you a bunch of videos with this posterior capsular rent. This is the only written slide that I have. The immediate goals of whenever you are faced with a situation is to extract all of nucleus, and if it's not possible, if it drops down into vitreous cavity, please don't chase it. Allow a vitreoretinal surgeon to intervene. Remove the cortex and epinucleus as completely as possible. Do an adequate anterior vitrectomy and preserve as much as possible the residual capsular support, whether it's the anterior capsule or posterior capsule. And if it is possible, implant the lens on the capsular supporters that is there. In case it is quite inadequate, either in the same sitting or another sitting when you are better mentally prepared, or you have a senior surgeon helping you, or instead of topical you have a peribulbar anesthesia, go ahead and do a iris clip lens or a scleral fixated intraocular lens. Once handled adequately, these cases do extremely well. And I think all my videos in this presentation are going to be running at 2x speed, so don't be bothered by the abruptness of the movements. I'm going to leave you with start with a message of hope. In the sense, this was a patient, physician from Ooty who came to me almost 2 decades back when he was 78 years old or something, and then we had this surgery going on. And as you can see over here, there is a fairly large PC rent that's there, and you can see the type of instruments that we're using, and anterior vitrectomy was done, and subsequently viscoelastic was injected in the just in front of the capsule, and there's a 3-piece intraocular lens that is going in. Mind you, this video is almost a couple of decades old, and I had this. This was a premium patient for me at that point of time. That's the intraocular lens which is placed in the, you can see a blob of viscoelastic which is behind. And before you create an optic capture, you have to remove that viscoelastic, go behind, whatever little vitreous is there, that's also removed. There's no triamcinolone acetate that was available. Very clearly you can see the area of PC rent and a fairly stable lens. And this picture was taken when the patient was almost 94, about 16 to 18 years later after the surgery. And no, this was soon after the surgery, and you can see with the PC rent and the way the lens has been implanted. And this picture is almost 18 years after the initial surgery. The patient maintained an excellent 6/6 visual acuity right through. So just because you have a PC rent on the table, at that point of time, our understanding, the kind of equipment, instruments we had available to us was also not as superior as what we have today. Once properly handled and you limit within your own capabilities, most often you end up with optimal results. This is a very small video clipping again, where the importance of not taking out your irrigation cannula till such time as you inject a viscoelastic is there. As far as you see a small PC rent that has occurred, as far as my irrigation cannula is inside, that was just flopping around. But the moment I take it out, the anterior hyaloid moves forward and immediately you get a PC rent which is extending. So obviously the most important aspect when you face a situation like this is to go ahead and whatever is the visco, if you have a dispersive viscoelastic, that's the way to go. Just in case you do not have access to that, then at least even a HPMC will do, but it's extremely important to reform the anterior chamber. And this is just another situation where you will see that while I'm polishing the posterior capsule, there's a fairly large rent that occurs in the temporal aspect. Now I'm doing the right thing in the sense the irrigation cannula keeps flowing inside. I'm injecting a viscoelastic, HPMC, and then subsequently the intraocular, single piece intraocular lens goes inside. So even in a situation like this, when the lens is being injected into the bag, it's possible to stick on to your original plan of injecting a single piece lens. And as far as the anterior hyaloid is not disrupted, there is no need for you to really do a anterior vitrectomy. I ensure that the lens is well placed within the bag, hydrate the incisions with the irrigation cannula in place so that there is no anterior movement of the intraocular lens, and that's the end of surgery. Here again, I'm quite confident with the way this patient has been handled. He is going to retain a good visual acuity for the rest of the lifetime of the patient. Most often, it's a posterior polar cataract where you end up with a situation like this. Everything seems to be proceeding fairly smoothly. Obviously, a 5 millimeter rhexis, no hydrodissection, just hydrodelamination. I do a stop and chop in this particular case, and that's not really an area of rent that I have created. It's only a deep trench. I bisect the nucleus, and as you'll see at the end of this, the posterior capsule is still intact after the entire nucleus comes out. But just to emphasize the fact that the capsule is always extremely weak in these cases, a simple polishing, you can see that there is an area of dehiscence of the posterior capsule that has happened. So again, the same principle in the sense that that's dispersive viscoelastic which is injected. And as far as the rent is manageable, either by doing a posterior capsular rhexis or because it's confined to a small area, you can go ahead and implant an intraocular lens within the bag. Now, it's a very extremely important aspect that you need to understand before we take a vitrectomy in these cases. Most of these machines come with an anterior vitrectomy, and that's the first step. What exactly does it mean? That is, in the first step, you only have irrigation. As soon as you go to the second step, both the cutting as well as irrigation, aspiration is activated. Now, with most modern machines, you have this IA cut and cut IA mode. When you are dealing with vitreous, essentially what you need to go on is a cut IA mode, where you cut the vitreous, then aspirate. First step is only irrigation, second step is cutting, third step is aspiration. And when you are doing this, and if you want to remove a little bit of cortex, then just in case, what you do is a IA cut, where basically you are staying in the second step and remove cortex. So you can go ahead and vacillate between these two steps to effectively remove vitreous without creating any traction on it. So please understand this concept of cut IA, where you cut first and aspirate second with irrigation flowing right through. Nowadays, with 4,000, 5,000 cut rates being available with many modern Phaco machines, the traction on the vitreous itself is very low. But in spite of it, so you can go ahead and use an anterior vitrectomy mode itself, where both cutting and irrigation aspiration is happening in step 2. But then it's always a good idea to use cut IA mode in these cases. This is the normal parameter setting when you are doing the vitrectomy. Ramp it up to the maximum cut rate that's available with your particular machine. Keep the intraocular pressure or the bottle height quite low. As you can see, it's just about 41 millimeters. Keep the vacuum as well as the aspiration low, and this would give you a more controlled vitrectomy whenever it's needed. Let's look at this case where a vitrectomy procedure was needed. And as you can see over here, I have a fairly large PC rent over there, and I inject viscoelastic, and you can see that a strand of vitreous that came in, and the irrigation is kept in the anterior chamber. I go in with a vitrector, do an adequate vitrectomy. Then even in this situation, because the rent was confined to a small area, just because it's not extending, I'm able to go ahead and place a single piece intraocular lens in the back. The small strands of cortex over there, but that even if you leave it behind, that will get absorbed over time. This is a fairly old video of mine, and that's the reason that I'm not checking with triamcinolone acetate in this case. Just in case you have a situation like this, where you are having a significant amount of nuclear fragments still remaining, and you have a PC rent, you can, things appear to be moving smoothly, an adequate capsular rhexis, fairly hard nucleus. Halfway through, one heminucleus is gone, but then I find that there's a fairly large PC rent that is there over there. So if the nucleus fragment had dropped inside, gone into the vitreous cavity, there's no way I would have done anything but called in a vitreoretinal colleague to handle this. But still, since it was still approachable, what I do is to go ahead and bring the nucleus fragment into the anterior chamber and fill in a bit of dispersive viscoelastic and there is a 3-piece lens. The patient had a 2.2 millimeter incision for the single-piece incision lens. I enlarge it to a 3-piece, enlarge it for introducing a 3-piece lens, place it inside, and with the intraocular lens itself acting as a scaffold to prevent the nucleus fragments from falling in, I go ahead and remove the nucleus, and now I go behind the intraocular lens with the irrigation in the anteriorly and do a good anterior vitrectomy. Diluted triamcinolone, usually in the phase of about 1:3, it is what is injected, and then it's ensure that the vitrectomy is quite complete, and make sure that your incisions are bereft of any vitreous strands. And this is again a step of using an IOL scaffold. You see there is a certain amount of cortex that is over there, and inject viscoelastic with the irrigation flowing inside. Introduce the intraocular lens of your choice inside. Here again a single piece lens is possible because I feel that there is adequate support for the capsule, remaining capsule to support the cortex, and subsequently I take out the cortical matter that is there. Just in case I had to, the capsular support was not was adequate, and I had to place a 3-piece lens, it would have been in the sulcus with an optic capture. So this is PCR that's occurring during initial chopping itself, and in this case, in the area of the large PCR, you inject dispersive viscoelastic. Viscoat is what I choose in these cases, and then subsequently you can bring out the nucleus fragments into the anterior chamber, and make sure that none of the nucleus fragments are going posteriorly, and with a spatula which is supporting, and refill the area of the PC rent whenever it is needed. It's possible even with a fairly large rent, there's refilling of the viscoelastic that is taking place. It's possible to remove the nucleus fragments quite completely, and you have to make sure, in case it's always a good idea a week later, or if the visibility is good a day later, to have a vitreoretinal colleague, or if you are comfortable doing a good vitreoretinal examination to make sure there's no nucleus fragments or cortex inside. Instead of allowing this to persist in the patient's eye for weeks together, nowadays sutureless vitrectomy is possible, and this needs to be attended right there and then. There's not a single case of dropped nucleus I'm going to show, because I believe that all the audience here are anterior segment surgeons, and once the nucleus slips inside, it's beyond the scope of control, and they need to call in a vitreoretinal colleague to go ahead and handle it. And that's a 3-piece lens which is injected into the sulcus, and an optic capture is also created to stabilize the lens. And it's extremely important that you ensure that there is no vitreous strands in the anterior chamber at the end of the surgery. And even a situation like this, you can see that there is a fairly large dialysis that is there. It's always a good idea in a situation like this to put in an endocapsular ring. But even using a single 3-piece lens where the haptics are fairly rigid, and using the haptics itself to support the area of dialysis is a good idea, and that itself would take care of this. But I would recommend normally to put in an endocapsular ring to facilitate more support for the area of dialysis, and then placing a 3-piece lens. Mind you, a rigid haptics of a 3-piece lens always gives better support than the single-piece pliable haptics. Last of my videos, fairly important patient, a gynecologist, underwent LRCS with a multifocal intraocular lens in the first eye. Second eye surgery, only now I noticed that there is some amount of debris in the posterior, in the vitreous cavity. That's when you can see at 6 o'clock there is a fairly large rent because of the extension of a capsular discontinuity. Basically what I do is to go ahead through the anterior route and do a good anterior vitrectomy. Irrigation cannula is just kept into the anterior chamber, and I'm extending the incision because I do not want to do a wound-assisted implantation. Avoiding the area of PCR, I go ahead and introduce the intraocular lens in the capsular bag. I know it's fashionable today to say that we do a pars plana vitrectomy in these cases. I did try it out in a few cases, but I believe that in my 3 decades of practice, anterior vitrectomy alone with the basic principles, tenets being observed, works very well. And though doing a vitrectomy through the pars plana route is also a good idea, at least in my hands, doing through the anterior route itself is quite adequate as far as doing the right thing at the right time. Thank you so much for your kind attention.